You finish a meal, you push back from the table, and within 20 minutes, your abdomen is visibly distended, tight, uncomfortable. You look 3 months pregnant from a bowl of salad. Or maybe it is not after meals. Maybe it is just there, low and persistent, by mid-afternoon every day, regardless of what you ate. Gas that is embarrassing. Bloating that disrupts your clothing choices. A gurgling, unpredictable gut that you have learned to plan your life around. And you have been told, probably multiple times, that it is the food. Cut out gluten, cut out dairy, try low FODMAP, stop eating beans. And maybe those changes gave you some relief, but the bloating came back. Because food was never the root cause. It was the trigger. And there is a profound difference between those two things. I want to be precise about this because the distinction changes everything. A trigger is something that provokes a symptom in a system that is already dysregulated. The root cause is why the system is dysregulated in the first place. Eliminating triggers is a management strategy. It reduces suffering in the short term. But if the underlying dysfunction is not addressed, the list of trigger foods will keep growing, the symptoms will keep returning, and eventually you will be restricting your diet down to 5 foods and still bloating on 3 of them. I have been in clinical practice for 15 years, and I see this pattern constantly. Patients who have been through every elimination diet, every food sensitivity panel, every digestive enzyme supplement on the shelf, and are still suffering. Not because they have not tried hard enough, but because they have been solving the wrong problem. If you want to understand your body at the level of mechanism, not just symptom management, then subscribe. I am working toward a community of people who want the clinical picture, not the simplified version. Hit the bell so you don't miss what's coming, because the gut content I have planned for the next few months covers territory most gastroenterology appointments simply do not have time to address. Let me tell you about a patient who illustrates this perfectly. He was 41 years old. He had been bloated almost daily for 3 years. He had done an elimination diet twice, identified wheat and onions as triggers, removed them, felt better for about 6 weeks, and then the bloating returned. By the time he came to me, he had also removed garlic, legumes, cruciferous vegetables, and apples from his diet. He was eating a narrow, frustrating menu and still distended by noon most days. He had been told his gut was sensitive and given a fiber supplement and a referral to a dietitian. What was actually happening was this. His small intestine was colonized by bacteria that belong in the large intestine. SIBO, small intestinal bacterial overgrowth, was producing gas from fermentable carbohydrates before they even reached the colon, where that fermentation is supposed to happen. But underneath the SIBO was the real question. Why were bacteria proliferating in the small intestine in the first place? Because his migrating motor complex, the muscular wave that sweeps the small intestine clean between meals, was impaired. And the reason it was impaired traced back to a bout of food poisoning 3 years earlier that had generated antibodies cross-reacting with intestinal nerve tissue. His immune system, in trying to fight the infection, had damaged the nerves controlling gut motility. The food was never the problem. It was the kindling on a fire that started with a pathogen and was being sustained by a dysfunctional motor system. Here is the biology you need to understand, because once you see it, you cannot unsee it. Think of your digestive tract as a self-cleaning oven with a very specific cleaning cycle. The cleaning cycle is called the migrating motor complex, or MMC. It runs approximately every 90 minutes during the fasting state, meaning between meals and overnight. It is a coordinated wave of muscular contractions that sweeps residual food particles, bacteria, and debris from the stomach through the small intestine and into the large intestine, where the vast majority of your gut bacteria are supposed to live. The technical term for this sweeping action is phase 3 contractions, and it is governed by a hormone called motility and the enteric nervous system, the 100 million neurons embedded in your gut wall that researchers sometimes call the second brain. When this cleaning cycle is impaired by stress, by eating too frequently, by post-infectious nerve damage, by medications like opioids, by thyroid dysfunction, or by chronic sleep disruption, bacteria migrate upstream into the small intestine and take up residence. When you eat, those bacteria ferment your food and produce gas, hydrogen, methane, or hydrogen sulfide, before your large intestine even knows a meal is coming. That gas has nowhere to go quickly. It accumulates, stretches the bowel wall, activates visceral pain receptors, and produces the tight, painful, visible distension that you experience as bloating. The food did not cause the problem. The food fed a problem that already existed in the architecture of your gut motility. Now let us go through the real causes of chronic bloating, gas, and flatulence in a systematic way, because there are several distinct mechanisms, and knowing which one you are dealing with changes the approach entirely. Cause 1. Small intestinal bacterial overgrowth, SIBO. This is the most commonly missed diagnosis in the chronic bloating picture, and the research on its prevalence is striking. Studies published in the American Journal of Gastroenterology estimate that SIBO may be present in up to 78% of patients with irritable bowel syndrome, a diagnosis that is often given when no other cause is found. The hallmark of SIBO bloating is that it typically worsens throughout the day, minimal in the morning, progressively worse by afternoon and evening, and is triggered by fermentable carbohydrates, even healthy ones like apples, oats, garlic, and onions. The diagnosis can be confirmed with a lactulose or glucose breath test, measuring exhaled hydrogen and methane. The standard treatment is a course of rifaximin, a non-absorbable antibiotic that acts locally in the gut, with a success rate of approximately 60 to 80% in clinical trials. But without also addressing the underlying motility dysfunction, recurrence rates are high. Cause 2. Impaired migrating motor complex. Dysmotility. As I described in my patient's case, this is frequently the root beneath the SIBO. The MMC can be impaired by multiple mechanisms. Post-infectious dysmotility, caused by immune cross-reactivity after food poisoning, specifically involving Campylobacter, Salmonella, and E. coli infections, is now well documented in the research of Dr. Mark Pimentel at Cedars-Sinai, whose work identified anti-vinculin and anti-CDTB antibodies as measurable markers of this damage. This is now a commercially available blood test. Dysmotility can also result from hypothyroidism. The thyroid hormone T3 is required for normal gut smooth muscle function, and even subclinical hypothyroidism can significantly slow transit time. It can result from autonomic nervous system dysfunction, chronic psychological stress, and critically from the habit of eating too frequently, which prevents the MMC from ever running its full cleaning cycle. Cause 3. Visceral hypersensitivity. The gut wall is lined with mechanoreceptors, nerve endings that sense stretch, pressure, and distension. In individuals with visceral hypersensitivity, these receptors are calibrated to a lower threshold, meaning a normal amount of gas in the bowel produces a pain and discomfort signal that a person without hypersensitivity would not register. Research published in Gut has shown that many patients with IBS and functional bloating have normal or near normal gas volumes, but dramatically heightened awareness of that gas. This is not psychological. The nerve calibration is a measurable physiological difference. It is often driven by a history of gut inflammation, infection, or chronic psychological stress that has altered the sensitivity of the gut-brain axis. Cause 4. Dysbiosis of the large intestine microbiome. Even when the small intestine is appropriately bacteria-free, an imbalanced large intestinal microbiome produces excessive gas. Specifically, a dominance of methane-producing archaea, Methanobrevibacter smithii, is associated with severe constipation and bloating because methane gas actually slows intestinal motility as a neurotransmitter-like signal. Research from Dr. Pimentel's group has shown that methane-dominant gut microbiomes produce a distinct pattern of constipation-predominant bloating that responds specifically to a combination of rifaximin and neomycin, or alternatively to specific dietary strategies that reduce methane-producing substrates. Cause 5. Carbohydrate malabsorption, lactose and fructose. This one is legitimately food-related, but it is specific, not general. Lactase deficiency, the inability to digest lactose, affects approximately 65% of the world's adult population outside of Northern European descent, according to data from the National Institutes of Health. Similarly, fructose malabsorption, an impaired ability to absorb free fructose in the small intestine, is common and produces bloating and gas, specifically with high fructose foods. The distinction between this cause and SIBO is that carbohydrate malabsorption produces a consistent, predictable response to specific foods, while SIBO tends to produce bloating that worsens progressively through the day, regardless of exactly what was eaten. Cause 6. Gastroparesis and impaired gastric emptying. When the stomach empties too slowly, a condition called gastroparesis, food ferments in the stomach rather than moving promptly into the small intestine. This produces upper abdominal bloating, early satiety, nausea after eating, and a feeling of food, quote, just sitting there for hours after a meal. Gastroparesis can be idiopathic, post-viral, or related to diabetes, where autonomic neuropathy impairs the vagal signals governing stomach motility. A gastric emptying study, a nuclear medicine scan, is the definitive diagnostic test. Clinically, I find this cause is frequently missed in patients who have upper predominant bloating that worsens in the hour immediately after eating. I want to stop here and ask you directly. Drop your age in the comments. I am asking because the causes of bloating shift with age in ways that matter for the solution. If you are under 40, SIBO and dysmotility are the most common culprits. Between 40 and 60, hormonal transitions, particularly declining progesterone and estrogen in women and declining testosterone in men, significantly affect gut motility, and the microbiome undergoes measurable shifts. Above 60, gastric acid production declines, a condition called hypochlorhydria, which impairs protein digestion and allows bacteria to survive in environments where they would normally be killed by stomach acid. Your age tells me where to look first. Now, here's the protocol. This is what I would walk a patient through systematically, and the evidence basis for each step is real. Step 1. Extend your fasting window between meals to allow the MMC to run. This is Tier 1. The mechanism is well established. The MMC requires a minimum of 90 minutes in the fasting state to complete one cycle. If you are grazing, eating every 2 to 3 hours, snacking constantly, having a pre-bedtime snack every night, you are never giving your small intestine the cleaning cycle it needs. The practical instruction is this: eat 2 to 3 structured meals per day with a minimum of 4 hours between them, and stop all food intake at least 3 hours before bed. No snacking between meals. For many patients with SIBO and chronic bloating, this single change produces measurable improvement within 2 to 3 weeks. Step 2. Test, do not guess. This is Tier 1 for the testing approach, even if some treatments remain Tier 2. If you have had chronic bloating for more than 3 months, ask your physician for a lactulose breath test for SIBO, a thyroid panel including TSH and free T3, and fasting glucose and insulin. If you have a history of food poisoning followed by gut dysfunction, the antivinculin and anti-CDTB antibody panel, marketed as IBS Smart, is now commercially available and can confirm post-infectious dysmotility. Do not spend years eliminating foods when a specific diagnosis is accessible. Step 3. Address the motility problem directly. This is Tier 2, emerging but mechanistically sound. Prokinetic agents, medications or supplements that enhance gut motility and specifically support the MMC, are a cornerstone of SIBO treatment and prevention of recurrence. Prescription options include low-dose naltrexone and prucalopride, which have evidence bases for gut motility improvement. Natural prokinetics with clinical support include ginger extract, specifically at doses of 1 to 2 grams per day, which research published in the European Journal of Gastroenterology has shown enhances gastric emptying, and Iberogast, a multi-herb preparation with multiple randomized controlled trials supporting its effect on functional dyspepsia and motility. Step 4. Rebuild the microbiome strategically, not randomly. This is Tier 2. Not all probiotic supplements are equal, and some strains can actually worsen SIBO by adding more fermentable bacteria to an already overpopulated small intestine. The most consistently supported strains for gut dysbiosis are Lactobacillus plantarum, Bifidobacterium longum, and Saccharomyces boulardii, the latter being a yeast-based probiotic that is not affected by antibiotic treatment and has specific evidence for reducing SIBO recurrence. Equally important is feeding the beneficial bacteria of the large intestine through diverse plant fiber, aiming for 30 or more different plant species per week, as research from the American Gut Project has shown this threshold is associated with significantly greater microbiome diversity. Step 5. Address your stress response as a gut intervention. This is Tier 1 for the mechanism. The vagus nerve, the primary communication channel between the brain and the gut, is exquisitely sensitive to psychological stress. Chronic stress activates the sympathetic nervous system and suppresses the parasympathetic tone that governs healthy gut motility. Research from the Mayer Lab at UCLA has demonstrated that chronic psychological stress measurably alters gut permeability and microbial composition in ways that are directly relevant to bloating and motility dysfunction. The practical intervention is consistent vagal tone training, diaphragmatic breathing for 5 minutes before meals, humming, cold water on the face, and social connection, all of which have measurable effects on vagal tone and therefore on gut motility. The bottom line is this: bloating is not a food problem. In most chronic cases, it is a motility problem, a microbial architecture problem, or a nervous system problem, and food is simply the match that lights a fuse that was already there. The frustrating cycle of elimination diets that provide temporary relief followed by returning symptoms will continue until the underlying mechanism is addressed. You deserve a diagnosis that explains what you are experiencing at the level of cause, not just trigger management. Test your system, restore the cleaning cycle, address the root. That is the path out. Your health is your responsibility, not the pharmacy's. I'll see you in the next video. Let me also address something that I think is critical and almost never discussed in the bloating conversation: the role of stomach acid. I mentioned hypochlorhydria briefly in the context of older patients, but this deserves a full explanation because it affects people of all ages and it is directly counter to one of the most widespread medical interventions for gut symptoms. Adequate stomach acid, hydrochloric acid with a pH between 1 and 3 in the fasted state, is your first line of defense against bacterial overgrowth in the upper gastrointestinal tract. It kills pathogens, it denatures proteins to begin digestion, and critically, it creates an environment that is inhospitable to bacteria that try to migrate upward from the lower gut. When stomach acid is suppressed by proton pump inhibitors, which are among the most prescribed medications in the developed world, that barrier is lowered. Research published in JAMA Internal Medicine has shown that long-term PPI use is associated with a significantly elevated risk of SIBO, Clostridioides difficile infection, and microbiome dysbiosis. This is not an argument against PPIs when they are genuinely indicated for erosive esophagitis, Barrett's esophagus, or active peptic ulcer disease. They are essential medications. but they are also among the most overprescribed drugs in clinical practice, given to patients with functional heartburn or mild reflux, where lifestyle modifications would be both safer and more effective. If you are on a PPI and you have chronic bloating, that connection is worth discussing with your physician. The diagnostic and treatment sequence I have outlined matters because the symptoms of too much stomach acid and too little stomach acid can look identical. Heartburn, upper abdominal discomfort, bloating after eating. This is why self-diagnosis and self-medication in this area are particularly risky. Functional testing. Either the Heidelberg pH capsule test or clinical response to a careful betaine HCl challenge under guidance can help distinguish between the two. This is Tier 2 territory in terms of the evidence base for specific testing protocols, but the underlying mechanism of acid as a barrier to microbial overgrowth is well established and Tier 1. There is also the question of bile acid sufficiency, which is a factor almost no one mentions in the context of bloating. Bile acids, produced in the liver and stored in the gallbladder, are released into the small intestine when fat is consumed. They not only emulsify dietary fat for absorption, they also have potent antimicrobial properties and serve as another layer of protection against bacterial overgrowth in the small intestine. Individuals with sluggish gallbladder function, those who have had cholecystectomy, gallbladder removal, or those with impaired liver function may have inadequate bile flow, compromising both fat digestion and the antimicrobial environment of the small intestine. Symptoms of bile insufficiency include bloating, specifically after fatty meals, light-colored or floating stools, and a history of gallstones or gallbladder removal. Research published in the journal Gut has documented elevated rates of SIBO in post-cholecystectomy patients compared to controls, supporting the role of bile as a protective factor. Another mechanism worth naming explicitly is the connection between thyroid function and gut motility, because it is underappreciated and clinically very relevant. Thyroid hormone, specifically triiodothyronine, T3, regulates the speed of virtually every metabolic process in the body, including the contractile activity of smooth muscle in the gut wall. Even subclinical hypothyroidism, meaning a slightly elevated TSH with thyroid hormone levels still within the normal range, can produce meaningfully slowed gut transit time. Research published in the World Journal of Gastroenterology has documented a strong association between hypothyroidism and both constipation and SIBO. What makes this particularly frustrating for patients is that their TSH may be reported as normal when it falls between 2.5 and 4.5 milliunits per liter. But growing clinical evidence suggests that optimal gut motility requires a TSH closer to the lower end of that range, ideally between 1 and 2. This is an area of genuine clinical debate. Some endocrinologists would dispute the narrow optimal range, which makes it Tier 2. But the biological mechanism linking T3 to gut smooth muscle is Tier 1. The final piece I want to add to this picture is posture and the mechanical dimension of bloating. The vagus nerve exits the brainstem and travels through the thoracic cavity and diaphragm before innervating the gut. Chronic forward head posture, thoracic kyphosis, and diaphragmatic dysfunction, which are endemic in a society that spends 8 to 12 hours a day seated and looking at screens, impair the mechanical transmission of vagal signals to the gut. Research from the Journal of Physical Therapy Science has demonstrated that postural correction exercises significantly improve heart rate variability, a surrogate marker of vagal tone, and there is clinical evidence that diaphragmatic breathing training can improve functional GI symptoms, including bloating. This is Tier 2 for direct bloating outcomes, but the mechanistic pathway is coherent and the interventions are zero risk. Spending 5 minutes before each meal in a tall, open posture, breathing diaphragmatically, is not only a vagal toning exercise, it prepares the gut mechanically and neurologically for the digestive work it is about to do. You can resolve chronic bloating, not by finding the perfect elimination diet and living on it forever, but by understanding why your gut motility, your microbial architecture, your acid environment, and your nervous system tone have drifted from where they need to be, and systematically restoring each one.